I'll just take a look. I just look at the screen then. All right. So what should we do before patient is admitted for endoscopy? I think the objective of our evaluation is to decide on the risk, whether the patient requires to be admitted to hospital, decide on whether the patient requires early endoscopy, and by early endoscopy I mean within 24 hours. What other therapy can we provide to the patient before endoscopy, and how do we assess the prognosis of this patient? So here is a list from the international guidelines of the management of upper GI bleeding for you to consider. First of all, immediate evaluation and initial resuscitation. And I will show you some of the important criteria for the evaluation. And then stratify the patient to low or high risk for subsequent management. Consider placing an NG tube. What we normally do is that we do not use an NG tube for all patients unless the patient has massive hematemesis and you want to empty the stomach, avoid aspiration, and to make subsequent endoscopy easier. Blood transfusion, there is some very interesting data published last year, which I would like to discuss with you. How much blood should we give to this patient? We used to believe that when patients comes in with bleeding, we will transfuse them with blood. The more, the better. But the recurrent evidence suggests otherwise. Correct the coagulopathy, use pro-motility agents such as erythromycin to empty the stomach so that the patients, if they require endoscopy, will not have a totally filled stomach with blood that make the endoscopy very difficult. And then how do we select the patient for early endoscopy? So here, first of all, let's look at the initial evaluation. There are, in fact, more than 10 different types of scoring system in the literature on how to assess patients' initial clinical status. And the most important ones are listed here, namely the Rocco score and the Blatchford score. Both comes from Scotland for some reason. And although there are many types of scoring system, but they all use slightly different criteria, and they were designed for slightly different purposes. For example, some are to look at the primary outcome of the patient, such as whether the patient is likely to die or whether the patient will likely to require endoscopic intervention. Whereas others will look at something else like whether this is a upper GI bleeding or a peptic ulcer bleeding, and what kind of endoscopic treatment is beneficial. So all these scoring systems are slightly different, but I would suggest that we only focus on these two, and that is the Blatchford score and the Rocco score. I apologize for the small prints in this slide, but basically the Blatchford score use a number of clinical parameters from the hemodynamic status, blood pressure, the pulse, the blood urea, nitrogen, the hemoglobin level, and also other clinical parameters to decide whether or not a patient is likely to require endoscopy. On the other hand, in the Rocco score, there are in fact two different sets of criteria. The first set, the so-called pre-endoscopy score, includes the age, whether the patient is in hemodynamic instability, and other comorbid illnesses. This is the pre-endoscopy score, which will be echoing the effects of the Blatchford score to decide whether the patient is likely to require endoscopy. Therefore, I think the pre-endoscopy Rocco score and the Blatchford score are important for us working in the ER or in your primary care clinic to decide whether or not the patient should be referred to hospital for early endoscopy. And if the patient has advanced age with comorbid illness, with blood pressure lower than 100 millimeter mercury or the pulse higher than 100, I think these are the are the red lights telling you that the patient is likely to have continuous bleeding. So risk stratification is important, and the Bradford score, the scale, compare favorably with the pre-endoscopic Rocco score in identifying high-risk patient for rebleeding or mortality. The Baylor and the Cedars-Sinai and the Rocco score also are useful in finding the low-risk patient. Now, why do we need to find the low-risk patient? If you can identify that this is likely to be a low-risk patient, they might not need to go to hospital. Or even when they come to the ER, they can be discharged home. We find that a lot of relatively young people, after a few drinks, maybe they cough, they vomit some coffee ground substances, and they're hemodynamically stable, will not admit them to the hospital. So both finding the high risk as well as the low risk population are important. And the Rocco score yields a more accurate diagnosis and a shorter duration of hospitalization if the prognosis is good. Now, I want to show you this study from the United States and also from Hong Kong to tell you when is endoscopy required. There were initially three different studies from the US finding that if the patients comes in at weekend, they will have a higher mortality from upper GI bleeding. I don't know whether it is the same in Greece. And I don't know when do your weekend starts, on Thursday or Friday or Saturday. But people in the United States, they found that if the patients present to hospital on Saturday or Sunday or during a long holiday, the mortality was higher. Now, when we look at this data, we go back to our registry of upper GI bleeding with over 10,000 cases, of which 9,375 confirmed to have bleeding from peptic ulcer disease in Hong Kong. And we divide them into holiday admission or weekend admission into these two. Okay, so if they comes in on the holiday or weekend, this should be weekday. This is holiday. This is not weekend. All right. So this is from Monday to Friday. Of course, the number is higher. We did not find any difference in the outcome. So this is slightly different from the U.S. finding. Why is that the case? Why the 3 American studies shows that weekday is better than weekend, but we did not demonstrate such a difference. I think the message is that if you go to a hospital in Hong Kong, whether it is Saturday or Sunday or New Year Day, you will still get endoscopy done within 24 hours. Whereas in some of the hospitals in the US or some other countries, 24-hour endoscopy service is not necessarily available, especially in the community hospitals. So for patients who have been admitted to hospital yet, they're waiting for the weekend before they can get endoscopy done, say 2 days or 3 days later, their survival rate is jeopardized. And this, in fact, is the reason. And we do believe that if you can offer endoscopy within 24 hours, it is good enough. There are studies who look at endoscopy within 6 hours or 12 hours after admission, and there is no very solid data to suggest that this so-called very early endoscopy has conferred better protection to the patients. Now, blood transfusion. The international guidelines said blood transfusion when the hemoglobin is below 7. Now, at that time when this guideline was established, there was just some very weak evidence to support this notion. However, last year, in 2013, there was a very large study with 921 patients with severe upper GI bleeding who were randomized to either a restrictive transfusion strategy, that is only when the hemoglobin falls below 7, or a liberal strategy in which the transfusion was decided by the physician. And they look at the outcome of these two groups of patients, restrictive versus liberal strategy for blood transfusion. And they found that if you follow these patients for up to 6 weeks, the restrictive strategy actually fared better than the liberal strategy in terms of death. The mortality was lower in the restrictive group compared to the liberal transfusion group. That means more transfusion do not necessarily doing any good to the patient. Here, the result is put into a table. You can see that the type of pathology were similar, but it is important to notice that about 1/4 of this series is bleeding from varices. And we know that patients with varices, if you give them a lot of blood, the portal pressure will goes up, the intravaricial pressure will goes up, recurrent bleeding is more likely to occur. Cirrhosis was found in 31% of cases. And the initial hemoglobin level was about the same, but in the restrictive strategy group, the hemoglobin was obviously lower than the liberal strategy group. And on discharge, it was also lower. And the important outcomes are shown here. Mortality within 45 days, 5% versus 9%. Further bleeding, 10% over 16%. Hospital stay, 9.6 days versus 11.5 days. Adverse events including heart failure, pulmonary decompensations, and so on, also is found more common in the liberal transfusion strategy. So all these important outcomes are actually worse when patients receive more blood transfusion. I think this is quite strong evidence for upper GI bleeding associated with portal hypertension, and it might even be true also in peptic ulcer bleeding. But the rationale behind is not entirely clear. So finally, what kind of patient will be benefit from our medication before endoscopy? Endoscopy within 24 hours is recommended. I have mentioned it. But should we start with some pharmacological treatment, especially when early endoscopy is not possible, when your hospital is a little bit far from the referral center, and therefore, is there anything we can offer to the patient? H2 blocker is not recommended. Somatostatin and triotide are not recommended unless you are quite confident that this is a portal hypertensive case and variceal bleeding is a possibility. IV infusion of PPI should be used after endoscopic therapy. After you confirm that the patient has bleeding ulcers, IV PPI is found to be useful. The results is quite convincing from all the studies in the literature. It favors, initially, the European study and the Asian study seems to be contradictory. The results seems to be conflicting. Then we were asked to conduct a multinational studies with 16 countries, mostly European countries, but also Asia from Hong Kong, and also one center from Africa. And the comparison was between using IV Nexium followed by oral Nexium for up to 3 days, and then follow with oral Nexium for up to one month. And in the other group, Nexium was not given. And here, both patients receive endoscopic treatment, and you can find that those who receive IV PPI together with endoscopy have a 50% reduction risk of further bleeding from the ulcer. And this benefit is also found in the intention to treat analysis. It is also found, here is the Kaplan-Meier curve showing the 50% difference. And you can see that the 3 days of IV proton pump inhibitors really cover the most dangerous period of recurrent bleeding. Therefore, if the patient is still in hospital, we give them high-dose infusion of PPI. It reduces the surgery rate, it reduces the repeat endoscopy rate. The mortality has not reached a statistical significance. The benefit is shown in any types of endoscopic treatment that you provide. And it is even more impressive if the patient has H. pylori infection. The positive HP positive group has a more profound reduction in recurrent bleeding rate. Why? Because we believe that H. pylori infection work as an endogenous PPI, and now you give more PPI, you totally shut down the exit in the stomach. However, my question was really whether PPI should be given before endoscopy. And this study run by Dr. James Lau in our group is to try to see whether before endoscopy, omeprazole or IV omeprazole given to this patient has any benefit. The result shows that if you give IV PPI before endoscopy, during the time of endoscopy, you will see less actively bleeding ulcer because most of the ulcer have stopped bleeding temporarily. And that is the only advantage. But in terms of subsequent management, surgery, recurrent bleeding, and mortality, there was no difference. What does that mean? It means that the patient with active oozing or spurting may be temporarily controlled by IV PPI, buying time for endoscopic intervention. However, you will still require subsequent definitive treatment, otherwise the patient is going to have recurrent bleeding again. And my final word is those who are taking aspirin or, for that matter, taking other antiplatelet agents and developed bleeding. What should we do with them? This is getting a more important condition because Helicobacter is disappearing, but a lot of our patients nowadays are taking aspirin or NSAID. And we have done a study to try to see whether aspirin should be withheld for a total period of 8 weeks while giving patients endoscopic treatment and PPI, or we should continue the aspirin while continuing the PPI. And these are patients who must have cardiovascular complications, or they may have a stroke in the past that indicate the use of aspirin. And the finding was quite interesting because although the one who received aspirin, you would expect to see more recurrent bleeding, and indeed it was higher, 18% versus 12%. So there were more recurrent bleeding in the aspirin group. However, the mortality was lower if you give aspirin to this patient instead of withholding the aspirin. There were 10 people die in those when we withheld aspirin, and only 1 in the aspirin group. And they died not from bleeding, they died from cardiovascular and cerebrovascular complications. So I think the message of this study is that when we look at the patient, we should see the patient as a whole. Gastroenterologist tends to focus too much on the bleeding, whether it is under control. So the bleeding is controlled, but the patient dies of cardiovascular disease. I think the message is that in high-risk patients, we should resume the antiplatelet agents as soon as possible in order to save life. So the take-home message, ladies and gentlemen, is that we should do a risk stratification considering the hemodynamic parameters, the age, comorbid illness. This is to find out who might require hospital admission and early endoscopy within 24 hours. For those who are very low risk, they can be discharged right away. But do not overtransfuse patients with blood. Hemoglobin above 7 would not require immediate transfusion. Patients may benefit from preemptive use of proton pump inhibitors, and do not stop antiplatelet agents for too long because you are jeopardizing the patient's cardiovascular or cerebrovascular diseases. Thank you very much for your attention.
Thank you, Joseph, for that fantastic overview. Any questions for Joseph? Because GI bleed is such a common problem in clinical practice. Yeah, please.
First, the study about blood transfusion. Does it take
Mike, can you use the mic, please? Yeah.
The question was, in the transfusion study, was comorbidity adjusted in the two groups of patients? Yes, it was. So those who have blood transfusion or the restricted transfusion have as many comorbidity as the liberal transfusion group. So in other words, the two groups are very comparable, except that the strategy of blood transfusion was different.
Any comment, especially about ischemic cardiomyopathy in this study?
As far as I remember, they have compared all the comorbid illnesses, and there was no significant difference between the two groups. I understand your concern that patients who have ischemic heart disease, they are more likely to develop heart failure with overtransfusion. That might be one of the explanations why they have more mortality with this transfusion policy. But at the baseline, the two groups seems to be pretty much the same. All right, there are certain percentage of patients who have ischemic heart disease, cerebrovascular disease, pulmonary diseases, so on. But if you give more blood, definitely you are more likely to jeopardize patients' cardiac functions.
No, I'm referring about a guideline, American Heart Association. They say that you are at risk for a heart attack if hemoglobin is less than 9.
Right. So we have a tough choice between 7 and 9 in that case. Keep the hemoglobin at 7 to 9 in that case. Well,
no, I think that this was the reason for why those numbers were chosen,
yes.
7 and 9, and
Right.
compared to each other.
Yeah.
My second question is, when you have a patient with hematemesis and EGD is negative, American Board of Internal Medicine recommends to repeat the EGD. Don't jump to any other unless you don't repeat it. When?
When?
How many days? How many weeks? How many?
There is no straight rule on when should you repeat the endoscopy. I would usually observe the patient for 1 or 2 more days, look at the hemoglobin level, and to observe for any recurrence of hematemesis. If the patient, after coming back from the endoscopy room, have a repeated hematemesis 1 hour later, I would not wait for 1 day or 2 days to repeat the endoscopy. I think the time of hematemesis is the best time to find out where bleeding comes from. So there is no absolute guidelines on when is endoscopy should be repeated. There are several possibilities that we have to consider in such circumstances. I have encountered patients who have a fistula between the aorta and the esophagus, aortoesophageal fistula. Patients can have very massive hematemesis, usually due to chicken bone or fish bone penetrate through the blood, through the esophagus. And they have very massive hematemesis. And then you go in, you wash out all the blood, and you did not find anything abnormal because it's very, very difficult to find the fishbone and the fistula between the esophagus and the aorta. And that's something that you might want to think about, or a ruptured aneurysm, and that kind of thing. So a CT scan of the thorax may be useful in such circumstances.
Yeah, one last question.
One last question. Thank you for the speech. When the hemoglobin falls below 7, do you have a target when you transfuse a patient? For example, 1 unit, 2 units, 3 units. Are there any variables that you use in that decision? What?
The amount of blood transfused does not give you a very good prediction of how much the hemoglobin will climb. It depends very much on the size of the patient and the level of the hemoglobin that he or she might have. So what would I normally do, especially in the elderly and frail patient who might have also a cardiac disease? I will give 1 unit at a time and see what would happen, and I would monitor the hemoglobin before I give some more. So I would be very cautious in giving. I usually would not write down 3 units of blood just like that, and the patients might be drowned in your blood transfusion.
So what you're saying is that you give 1 unit of blood and see whether the patient hold the level, holds the level of the units.
Yeah, based on the paper I shown you from the New England Journal of Medicine, it is good enough to maintain the hemoglobin level above 7. You don't need to go beyond 10. All right, so it's anywhere between 7 or 9 or 10, I think it's good enough.
Thank you, Joseph. On behalf of the organizers, my co-chair, I'd like to thank all the speakers for the excellent talks and the audience for the participation. We now break for tea.
There's a coffee break, and the next session will start in half an hour.
Thank you.